So, good morning everyone. Welcome to Cape Town and ASLM 2023, and welcome to our TB session. It seems people are partial to that side of the room, which is fine. That's okay. Yeah, so I know I'm so very glad to have all of you around attending this very special session that took us quite a bit of time to put together. Preparation started way back in July, and now to come and see it happening is really a great joy for us. So just to introduce myself, my name is Marguerite Masinga-Wembe. I'm a senior scientist with the African Society of Laboratory Medicine. I'm also the chair of the Stop TB Partnership Global Laboratory Initiative, and I'm the lead for the dissemination work package of the TB CAPT consortium. So you will be hearing more about the TB CAPT consortium soon. I think 2023 has been a good year for TB. So we've seen that the number of notified TB cases has reached 7.5 million, which is the highest number recorded since WHO started following and reporting on the TB, I would say pandemic as far as I'm concerned, but the TB epidemic globally. And it shows also good signs of recovery from all the disruption that we have experienced due to the COVID-19 pandemic. However, I don't think we can rejoice yet. 3 million cases still remain undiagnosed. Of those who were diagnosed, only 47% had access to WHO recommended rapid molecular diagnostic tests, rapid diagnostic tests. And for those affected with MD or TB, so only 2 out of 5 could be diagnosed and get access to an effective treatment. ASLM is really committed to increase equitable access to quality-assured, patient-centered diagnostic services. In 2023, we really started expanding our tuberculosis work stream. And this has been possible through collaboration with various partners. We do have activities that we implement with CDC. We have also, I would say, blossoming relationship with the Stop TB Partnership. You will be hearing more about that. And also, we do have joint webinar that we organize with the Global Laboratory Initiative. But one of our flagship projects really this year and the year before. I mean, this one is like the fight against TB. It has been put on hold because of COVID-19 pandemic, but now we're really getting to the end, and we have exciting evidence to share, and that is the EDCTP funded TB CAPT consortium. The EDCTP funded TB CAPT consortium is led by FIND, and as I was explaining, ASLM is in charge of the dissemination. And the purpose of the dissemination work package is really to leverage the tools that ASLM has launched, among which the LabCop, which is the laboratory community of practice to strengthen lab networking system. And we aim really to fast track the gap between new diagnostic tool development to make sure that they are adopted and scaled up in a timely fashion by countries. And so without further ado, I will give the stage to my co-host and co-chair, Adam Penn-Nicholson, who is representing FIND, who is leading the TB CAPT consortium. Thank you, and welcome again to Cape Town.
Morning, everybody, and thanks so much for coming, and to Marguerite and the ASLM team. I mean, I think a lot of effort has gone into this, but I can attest that I have not put as much effort in as ASLM. So well done, and here's to I hope it was a successful session, and by the program, I think we're ready for it. It's going to be exciting. And also, just thank you to all of you for your attendance and attention as well, and to the speakers who have agreed to participate and from all over the world for this. And just to state what TB CAPT is, it's an EDCTP funded project. It started in, the kickoff meeting was in Hyderabad at the Union in 2019. And boy, it's been a rocky road. I mean, I think it's been rocky for everybody in these years, but we pulled it off. The TB CAPT stands for TB Close the Gap, Increase Access, and Provide Adequate Therapy. So there's 3 trials within the TB CAPT consortium. I think there's 14 partner institutions in the consortium, and everybody's really pulled their way through thick and thin with no-cost extensions and difficult recruitments and delays and changes in scope of projects along the way. But we're coming to the end of the project now, and there's some really exciting results, and I think Dr. Sasakos is going to share some of it, and we're going to have presentations on cost effectiveness and qualitative work on a core trial, which we will hear more about, on the placement of bioelectronic instruments at the primary healthcare center. The other trial in the mix was led by Helen Cox as the senior lead PI on the feasibility and implementation of expert XDR test in South African laboratories. And then the third trial, which is still completing its enrollment, but we're getting very close now, I think we're at 70% enrollment, is the Exultant study, which is looking at hospitalized people living with HIV for expanded testing and diagnosis, and that's also an exciting stage. And so these trials have been conducted in South Africa, Mozambique, and Tanzania. A number of partners involved, and I think I'd just like to thank all the partners. You will hear about them and see them in the slides. And also just to make a comment to thank the developers and the manufacturers who kindly donated so many of the tests and instruments to allow these studies to happen. So I think a lot more bio, Cepheid, and community, and so I think that's important. And without further ado, I think let's get into the nuts and bolts and exciting session. And back to Marguerite for the
Thanks a lot, Adam. So we will be starting the session with some three quick keynote presentation. So I was saying at the beginning that preparation for this session started in July. I was sitting at Sao Tome and Principe in front of my laptop and communicating with Professor Madupai, who came all the way from Canada really to set up the concept also for this session. So those are nice memories, and as I'm saying, it's nice to see it happening now. And so we have really a great lineup of keynote speakers, and the first one will be Professor Nazir Ismail, which I met also a long time ago. He used to train us as for the WHO regional GLC, the Green Light Committee. Professor Nazir Ismail is currently the head of the Department of Clinical Microbiology and Infectious Disease at Wits University and NHLS Charlotte Maxeche, I hope I'm pronouncing right, Academic Complex in Johannesburg, South Africa. So Professor Ismail was formerly the lead for the diagnostic team at the WHO Global TB program in Geneva. And he was responsible for developing global policy, norms and standards for TB diagnostics and laboratory strengthening. And so we're very glad to have him here today, because as we say, what you don't measure, you cannot know, which direction you're going. And so Professor Ismail will be making a presentation on the new WHO standard for universal access to rapid TB diagnostics. So, Professor Ismail, you're welcome.
Thanks a lot, Marguerite, and good morning to all of you. It's great to see that TB is on the agenda at this meeting, and so much time is dedicated to an important topic that affects many people. The presentation will be on the WHO standard, as Marguerite indicated. Just to also note that this work was something I led when I was at WHO. And the acknowledgement for this work really go to not just the diagnostic team at WHO, but a huge amount of different people across the globe that contributed to the development of this work. So I'll just give sort of highlights on the WHO standard. But before getting there, I think Marguerite has sort of nicely pointed out the gaps. And what you see here on the slide, two flow charts essentially. The one giving the data from 2021, and on the right-hand side, 2022. And looking at the cascade, so you look at estimated to notified cases, notified that were WRD tested, notified to back confirmed. It cascades along all the way to RR testing, FQ testing, etc. And what you'll see is that by and large, I mean, theoretically, all of that should have been 100%. So we have gaps across the entire cascade. But there's certain gaps that are even larger than other gaps. And particularly, if you look at the notified to WRD tested in 2021, 138%. And the testing for Badacula and Linusad was just below 20% in 2021. When you look at 2022, as Martin has correctly pointed out, there has been, with the catch-up plan post-COVID, an improvement in the case detection for TB, which is really great to see. But you'll see that the other parameters, apart from the WRD access, which has improved, has generally remained fairly static, particularly back confirmation, RR-TB detection has not shifted much. But there has been some improvement towards Badacula and the Linusad test. Having said that, I mean, below 50% is a fail in most exams, right? So we definitely have problems that need to be particularly addressed. So essentially, the gap that we've seen, and when we reviewed the work that was done in terms of diagnostics and particularly WRD access, what you'll see the graph on the left-hand side, you have two lines. The black line is the WRD indicator of all notified cases, how many were actually offered a WHO recommended rapid diagnostic. And you can see that slow creep along the way. And just behind it is a green line which gives the proportion of TB diagnostic sites globally that even had a WRD on site. Right? So you can clearly see the very close tracking between access to the technology and the indicator that we prescribed. And in 2021, it was only a quarter of sites, and in 2022, a third of sites actually had access to this test. So clearly a major problem that we have. What's important also to appreciate is that the landscape has largely changed. While we initially had Cepheid as the primary diagnostic tool for over a decade, there's a whole landscape of different technologies now available with obviously various competing offerings that they have. A few pertinent issues just to appreciate is that when we're talking of diagnostics for TB, drug resistance is quite key. The timeliness of diagnostics, so while we call rapid diagnostics, it's important that it's not just in the lab, but actually impacting patient care. And the last issue is that a lot of TB occurs in low middle income countries, and quality assurance becomes tough. So the standard that was established by WHO and published this year actually focused on three main objectives: addressing the access issue to these rapid tools, and also linking that with case finding. The second was about bacteriological confirmation and particularly testing for drug resistance, and the last was around time to diagnosis. So the standard that I indicated really was developed through a lot of engagement. We decided to use a cascade of care framework, which basically follows 4 steps. It's primarily focused on access issues. And what's interesting, through the consultation we had, there was a key push towards having consideration for the private sector, which I'll come to a bit later on. And recognizing that with all these efforts towards providing access, this is a decade-old story, and appreciating value and respect and addressing enablers should be a key focus of what we do in this campus. So that's the links to the document and also the EMA publication that came along with it. So what is the standard? Essentially, as I indicated, it's a cascade of care approach. There's 4 steps. The first is about identifying presumptive TB. This focuses largely on screening, the use of chest X-ray, etc. That is an important screening tool. The second is around accessing the test. And this focuses about the algorithm that's used in the country. A key focus on primary healthcare access. And I think we're all moving towards universal health coverage. And PHC access becomes quite critical. Diagnostic coverage and testing capacity as other components. Step 3 is about being tested. So while you might have a test, are people being offered and being tested? And that's also about whether instruments are performing well, whether the quality assurance is there, and also whether the factors of resistance testing is part of that cascade. And the last is about receiving a diagnosis, not just about the testing, but also the turnaround time related to that testing, and whether the data that's being used is actually impacting on how the delivery of services occurs. One important thing on the left-hand side I'd like to highlight is that when we developed this benchmark, the 12 benchmarks that underpin this diagnostic standard, we've actually, as we went through the cascade and realized that it's not about a diagnostic test, but an ecosystem of diagnostics. So in fact, some of the indicators speak to district level work, some speak to the laboratory, some speak to the health facilities themselves, and the last speaks obviously to individuals within that health infrastructure. So all of these sort of led to a lot of cascading events across the ecosystem. And interestingly, from the early pilots that we've heard at the NTB Summit at the Women Conference, a lot of the countries were very just for this effort because it really forced them to coordinate and collaborate, and we hope that will lead to a greater impact. So what are the 4 steps and what are the details behind this? I think I'll just go through key snippets around the 4 steps. As I indicated, the one is around high-risk groups. These are sort of the low-hanging fruits, essentially. The pretest probability in a lot of these cases might be 3 to 7 to 10%. But yet, if you look at what the performance is, it's really suboptimal. Just actually has been underutilized for screening. So often we think of it as a diagnostic tool, but actually for screening, especially recognizing that a lot of the evidence now shows that symptoms are not adequate for detecting TB and for identifying TB. And that really highlights the weakness of symptoms, but also the need to move towards much more sensitive screening tools. On that basis, in the private sector, we've also incorporated, indicators around the testing of private sector populations like ex-mine workers, healthcare workers, etc., to be incorporated. The second step speaks about access to testing. Again, here, what's interesting is when you look at the literature, over 80% of people with signs and symptoms of TB appear at the primary healthcare level. Yet access at primary healthcare level in most parts of the world is exceptionally low. And as indicated, the indicators and the diagnostic access seem to be a particular problem. What's also important about the private sector is that when you're talking about access at primary healthcare, often we should also consider GPs and other kind of scenarios, particularly in many low middle-income countries or middle-income countries, where the private sector and GPs become a key component of care. And we don't really have any model that allows these rapid tests to be made available at an affordable price for patients in the private sector. So that's become an important component of care. Moving on to the next one around being tested. Again, here the issue of quality assurance using existing data for quality monitoring of error rates and instruments. But I'd like to really highlight the issue around drug resistance. And you'll see that the target there for universal drug susceptibility testing. Essentially, all TB patients should really have a DST performed according to their treatment program. And this should apply also equally to the private sector as well. And then the last step in this cascade is really around receiving a diagnosis. What's important to appreciate is particularly around the issues around pulmonary TB versus extrapulmonary. Even for pulmonary TB, we don't do a good job. Right? I mean, extrapulmonary, what we argue the sample size, etc., could be challenging. The tools may not be good enough. But for pulmonary TB, we still have major gaps that exist. We see with COVID in terms of positivity rates and impact on strategy, and this should be now a mainstay for TB as well. And the last thing that I indicated was really around the turnaround time, which although we claim it's a 2-hour test, but in reality the service delivery of that is far from that type of turnaround time. So that gives the 4 steps essentially in terms of what the standards about the 12 benchmarks that each country is now expected to measure and monitor over time and sort of coordinate efforts across funders, political, and implementers as well. So the last part, just quickly on WHO standards, so recognizing that we set this benchmark, the 12 benchmarks, we set the standard, but we recognize that this is not in isolation. There's been 10 years of effort in terms of rolling out these technologies, and there were many barriers that were faced, but also many solutions that were identified. So we undertook a systematic review to assess what were the barriers, what were the enablers, etc., across the cascade of care, mapping what were the issues in terms of being able to address the challenges that we've already faced so far. I'm not going to read all these bullet points, they're all in the document, but I think there's a few important things that came up. Issues around multi-component strategies. It's not just about the test, but also engagement with clinicians. There's a whole variety of things that need to go in package with the work that's being done. The key focus around multi-disease testing. As you become more decentralized, the burden of TB for testing may not be sufficient to cover utilization, and therefore cutting across different diseases will be quite important. The issues around the use of diagnostic network optimization and improvements were quite key. I mean, the sample referral system is quite integral to any diagnostic system. And then issues around the use of data to improve and particularly lab information systems that could provide faster results to clinicians and patients as well. And we did a focal group discussion with countries as well to really unpack what are the solutions that they had undertaken to address some of the TB gaps. It was quite varied, but a few highlights were quite fascinating. I mean, in Africa particularly, and also in Asia, power. I mean, even in South Africa we have load shedding, right? So power is a particular problem, and it's interesting. Solar panels are the thing of the future, right? Climate and all of that kind of stuff. And yet, these were Nigeria was the one example that really packaged solar panels as part of the package of care. So there are solutions that could address those problems. Market diversification became very key. Often service levels, support, etc. were a big issue. And market diversification was a key drive from countries. The second was around refresher training and incentives. The third often is the mobility of staff. And how do you sort of retain knowledge as mobility of staff? And I think from the COVID experience around video recording of trainings, etc., came out as quite a strong focus, as well as incentivizing staff. There were very tough environments, and how do we support and incentivize staff to ensure turnaround times are met. And the last is around the integration of public and private sectors. I think COVID was a very clear example of that. I mean, the capacity in public sector was largely poor in most settings, and the ability to leverage resources across the sectors was found to be quite powerful. And I think the same thing can be said for TB as well in some countries where the private sector plays a big role for TB. And then the second last component on this training was country case studies. So we just presented two. What's so fascinating with the Nigerian case study was what you see in the pictogram there on the top is how they approach implementation of the diagnostic. And they see it not just as an instrument, but as a package. So you see you have an instrument in the middle, but part of the package was a solar panel, a refrigerator. So, it's interesting, it's not just seen as in isolation, but the most fascinating for me that I picked up from that implementation case study was they took the SOP and they stuck it on the machine, right? Because staff leave and turn over all the time, right? So if a new person comes in, with a piece of paper, you follow step 8 to 10, right? And then you can deliver the service. The second one, the Philippines case studies, I think people are very familiar with the Spider's efforts around, sample referral using the Spider. It expanded to include, HIV testing and other disease testing, but they even gone further, right? They now deliver medications through the same system, right? So it's amazing that the innovations that are in challenging environments, people are creative, and we should leverage those examples to make sure that we can achieve universal access. So with those few words, just to summarize, the WHO standard is really like an effort through a global initiative, coordinated across countries, implemented, funded, etc., with a broader objective of improving access, and primarily not just access, but also identifying people that will reach access. Improving bacteriological confirmation is quite bizarre that we still have a lot of, empiric treatment for TB, right? And it's a very complex condition. I mean, look at cough and fever could be many different things, right? So there's an important need towards bacteriological confirmation and also drug resistance TB detection, which, as Margarita's points out, only 2 in 5 actually tested. And the last around is reduction towards time to diagnosis, which are really patient important outcomes that we kind of overlook often. We often look at the health system, but not the glory of the health system. So with those few words, thank you very much, and we look forward to update and support towards these efforts. Thank you.
I think given the format of the program, we're going to take questions at the end of each session. Right? And so hold your questions from the end. And next I'll introduce Dr. Madhupai and Dr. Puneet Dewan, who are sharing a session entitled Critical Transitions That Can Inform TB Diagnostics. I'm sure that you're familiar with both Madhu and Puneet. Prof. Madhupai is the inaugural chair of the Department of Global and Public Health at the McGill School of Population and Global Health, and he holds a Tier 1 Canada Research Chair in Epidemiology and Global Health. And he's the Associate Director of the McGill International TB Center and also the Chief of Plus Global Health, Global Public Health. And Puneet Dewan is a Senior Program.
During the COVID response. It addresses also the COVID testing. Now, I would like to share with you some results of the investment we have done. During the Challenge TB Eliminate TB project, this is only from July 2020 to September 2023, we have been seeing an improvement on notification. And as you may see, this is a comparison at the national level, at the supported region where the ETB elimination project is working, and other regions, to show you the impact of intervention on active case funding and other activity we are doing. And in the last 2 years, we managed to notify all TB forms 1,031,955 cases, and we have identified 733 RR cases. You can ask me why we have less RR DRTB cases for Ethiopia. I would like to remind the participant that Ethiopia was in the high burden DRTB cases in the last 20 years. And in 2019, Ethiopia, due to the effort of all the implementation of from USAID, but all other projects, Ethiopia was removed on the RR DRTB cases. The case of resistance is decreasing. And also what we would like to say is that 97% of DSTB cases and 91% of DRTB patients were treated successfully. The treatment success rate is very high. We start recently to scale up and to introduce and scale up the short regimen, the BPAL, in the country. This is also in alignment with the DNA funding, and we also scale up the XDR technology to support the first line and second line profile to be sure that we are putting in correct treatment. And recently we established an ICU for critical sick DRTB patients at St. Peter Hospital, where we are managing difficult cases, also supported when needed by surgery. This is to show you the DRTB enrollment, which is very high for the first time, than 90%, and we reduce also the repeat tested to 12%. As you remember, when the XDR cartridge, and before that, the algorithm for the algorithm with the reflex test, all RR cases have to be repeated to be sure that you have RR cases before you start the treatment, or you have to send that to the LPA, where you have a complete DST for first line. This algorithm was piloted in few sites, and then based on the result we observed, we start to review the algorithm, and then we decrease also the consumption of its cartridge to be sure that we manage a proper algorithm according to the country context. We'd like to show you also the deep dive data from the gene expert utilization, as you may see, supported by a diversification of contribution of specimen transportation. As you may know, in the last 2 years, Ethiopia faced a war, and there are some regions like Tigray region, Amra, which are very challenging. We try to develop new sample reference system to maximize the use and access to molecular testing, and you can see the increase on gene expert utilization. Recently, we introduced the XDR cartridge, and our pilot, I can say, first result are showing that we have less or neglected, I can say, resistance to capreomycin fluoroquinolone. But what we are seeing, the monoresistance to ANH is a little bit high compared to the resistance to rifampicin, which is around 1.1%. The monoresistance to ANH is more than 6%, which means that in the past, probably we have missing these cases, which we are starting to capture with the gene expert, the XDR cartridge. As I say, our placement of this machine was guided by all TIC, which is a Treatment Initiation Center, where we have also already other capacity to do LPA, which we will be discussing later in our lesson learned. The national performance of second line and second line LPA testing by the culture lab, as you can see, and the new line drugs which are part of the short regimen, the data is shown in these two graphs. You can see that the LPA demand is decreasing because of the deployment of the 10-color machine with the XDR cartridge, and also for now the capacity to do the new second-line phenotypic DSP for new drugs is only centralized at APHI. To support all this deployment of new technology, we have been also developing capacity of diagnostic and connectivity tools to be sure that we can manage reporting of results. But also during the COVID, this was leveraged to respond to the COVID demand. And the dashboard is placed at the APHI headquarters. But at each facility, they have access to the data, and all partners can share from HIV. This will be decentralized and integrated with other disease. This initiative of lab expert was developed under the EDCTP project, which was supported by Stop TB. And this is a south-to-south intervention developed by stakeholders from Uganda using the approach to be sure that we can sustain this connectivity tool after the project ends. I would like now to touch on target next generation sequencing. During the COVID response, the country received a lot of machines. We are trying to support the APHI to build capacity on next generation sequencing. We are now planning to have a training with partners with the collaboration with Africa CDC. The discussion is ongoing to build capacity of bioinformatics, and this will be mainly to support the rollout of GeneXpert XDR cartridge to link the second-line DSP, but also the introduction of short regimens to manage the resistance and to do surveillance, real-time surveillance on new drugs which are currently introduced. Lastly, is to share with you the impact of all this investment. This is an independent survey which was done under the EDCTP program, which is supported by Stop TB and a Step Up for TB project. And this was presented during the last Union conference. As you may see, Ethiopia now is scored 81%, which is an impressive score. But this is the result of many interventions coming from stakeholders, but also on policy change. Lastly, I would like to show the same data which is coming from this survey, which show you that all the pillars under diagnostic from the lab's perspective have been impressive, but we are still having a lab interface, clinic interface with treatment. And this is how we can speed up the introduction of short regimen for DSTP, but particularly from children, where we have new short regimen which is still lagging in Ethiopia, and we are working on policy change to improve and to be sure that children are not forgotten. And particularly, you can recall that Ethiopia was the incremental country where the pilot and scale-up of stool using GeneXpert was piloted and validated. Now, what is the lesson learned from this experience from Ethiopia? We learned that how to operationalize a lab network. First, develop strategy to address the placement of new tools, looking at the patient pathway. There was a publication which was done, I think, a few years ago to increase access to tuberculosis service in Ethiopia, looking on the pathway of analysis. This was done, I think, with many partners, and Bill and Melinda Gates, I think, was incremental on that. And this was our guiding document to show us where we have to place our machine and where we have to strengthen the system, and particularly the TB diagnostic network assessment come to support this exercise. And this takes us to the second lesson learned in how to strengthen the patient-centered approach and the lab clinic interface. looking on the clinician side, where we have CAT machine, which are now deployed at the country level, and linked this clinician to support the X-ray symptomatic cases with diagnostic, where we have a gene expert machine, but also capture and other capacity. And this supported by a referral system, but also a reporting system supported by a connectivity tool to have real-time results and short and early starting of treatment. Lastly, the lesson learned is the placement of new testing technology. Technology itself, even what we are seeing, is not enough. We need to develop a holistic package for sustainable implementation using a patient-centered approach. And our lesson is summarized in this graph. First is to prepare the lab and to be sure that we do a pre-assessment, to be sure that all the requirements for the technology is in place. And then we transfer the technology with all the supply and the quality management system in place, but also the end user capacity. And after that, we monitor the implementation by having some key performance indicators, but also looking at impact assessment and also sustainability. I would like to thank you and to thank USAID, our project team in the ground, our local partners, and we are working in Ethiopia. My colleague at the HQ participate on this project implementation, and thank you for listening.
Thank you to all the presenters for those interesting presentations. I think we will open the floor for maybe 10 to 15 minutes of questions. If we have the time, and I think this is important. So if there are any questions, perhaps I can ask the presenters to come up to the front, and there are microphones on the table. It might make it easier to respond if you and if there are any questions, there's a microphone in the middle, and I encourage.
Thank you very much. I'm Peter Van Hersden from the South African National Bioinformatics Institute. And amazing presentations, and very interesting in the last one as well to see that a part of my question was already answered. So in the case of Ethiopia, well, which has got a very complex TB picture, with both MTB and non-tuberculous bacteria circulating, that there is this NGS being put into place as well. And it's a question, I guess, for everybody. So how, at the moment, we rely on catalogs really built using northern research labs. So how can we, while rolling out all of these amazing things that we heard in the second presentation, sorry, not counting presentation, but how can we also make it work on the other end, so it was on the left-hand side of the picture, which is to basically look at the difficult cases, characterize the difficult cases, and feed it back into a collaborative, a knowledge base of what's happening, especially in the context of BPAL-M regimes, So that seems to be a little bit answered by the capacity building that Ethiopia is doing, but also in that strategy document, which is related to this, is the integration with information systems a key component, because for your beyond the patient management, for your epidemiology, if the data is not being captured and being reported to your control teams, then that's also a big gap.
Maybe I can respond to your comments around the catalog of mutations for characterization of drug resistance and interpretation. So I think you're aware that WHO issued a catalog of mutations in 2021. and 1 month ago issued the latest update, which addressed important gaps both on geographic representation. You'll see in the latest catalog a lot more data from Africa and Asia as well. It is not largely West Africa, North Africa, South. It's represented quite well in the data, number one. Number two, I think the biggest challenge with version 1, at least edition 1, was related to categorization of mutations to community that is to some degree already been addressed in the latest catalog that came out recently. It incorporates data, but also expert rules that are developed through a broad consultation with some experts globally on rules for enhancing the data. I think just for people to be aware, just go to WHO website and search WHO catalog of mutations to find the latest one come out. But I think it's not just the catalog of mutations, right? It's all the capacity building. It's not just there's a whole procedure, there's a process, and also understanding how to even deeply interpret mutations is quite important.
Okay, thank you very much for the wonderful presentation. I'm Catherine from Kenya. My question is on our last presenter. I would wish that to run any challenges or the aims you have for implementing tool using the GeneXpert in Ethiopia. What challenges did you go through and what is the yield currently?
Okay, thank you. I think because Ethiopia was selected as a pilot site, then our challenge can be like the past. Many of the challenges not currently where we are scale up, and now it's a routine approach. At the start, during the validation and the implementation of the kit, because it comes as a kit, even during this implementation is based on that we come with the complete kit, how we have to be as you receive that in the catalog or in the SOPs and the GDF catalog. The first challenge I can say is on the acceptability of the end users or the technician, because they was not exposed to that. They know that, as you know, at the facility level health center, they have already used tool for other purpose, but for parasitology, for example. And this was easy for us to work on that acceptability from the end users. The second issue is on the protocol implementation. To have the concentration and the product which need to go to the GeneXpert and to reduce the error rate. This was the big, I can say, big challenge. But now, as we have now the kit, the protocol is standardized and it's easy for implementation. The last, I can say, challenge we have is on the beneficial, because you need to have the parent or the community members knowing that they can come with the kit to the facility for this test, because this is a communication level. And what we are doing now at the community level, we are using the active case funding group, community health workers, to sensitize at the community level to say that for children, they don't need to come with school tool, they can bring up stool and then this can be tested. I think 3 level is acceptability from the end users. Second level is communication, how to collect the samples. And 3 is to the implementation of the SOP at the lab. This is the 3 levels we need to address when all to use during training to be sure that you address the 3 components. This the experience from now validation has been done, but I take in consideration before the validation. Thank you. I hope I address your question. Oh, the yield. What we observe, for example, it depends, as I say, on the prevalence of tuberculosis. Ethiopia is, as other countries, we have hotspots. And for example, now, because of the war, in the region where the population was moved and they didn't have, everything was destroyed, we are seeing cases coming up again, and particularly in this community, children. And the yield is high. It's not saying that the yield is high because the techniques is taking, we are detecting a lot of cases, but we are thinking that it's also due to the fact that this population was moving, and then they didn't have access for a long time with access to detection or to diagnostic. But what we are seeing in general population is that our children detection rate is going up, compared between sputum, when we compare the data we have before with the old algorithm compared to the new algorithm. Yeah, the yield in some cases it goes up to 12.3% in some zone where we call demonstration zone. But I cannot give you the overall picture because I didn't go inside the detailed data. But we are seeing a very high yield.
Thank you. My name is Makuma Kuna. I work for the EDCTP, and I really appreciate all the presentations that were given out. I want to have a question to ask a question to the last presenter. You spoke about having about 500 facilities with an expert platform, and I know that we've had some struggles back in our country with regards to scale up of this particular technology, just because of the investments that were required in terms of the infrastructural developments and improvements that were needed. And I wanted to understand if you faced any particular challenges with regards to, the infrastructural improvements of the facilities and the funding behind it, or was it just part of the entire project, that the project came with funding for the infrastructural improvements? But also any networking challenges that you faced. I don't know, back in our country, the internet is not as broad in terms of all the facilities. It would be, we face difficulties in getting internet in some facilities, and how would that affect, or how has that affected how you view the data, how you get access to the data? And lastly, maybe on the very same note, is have there any concerns about the data security? Because that has been a little bit of a concern, again, in my country for other platforms, not necessarily for the expert, but some national Ministry of Health, ministries of health may be concerned with the security of data now that it's moving around in the cloud and whatever. Thank you.
What I have presented is not 5 years project. The 503 machine which we have in Ethiopia start 2012 in different projects. This is one. Then it was a gradual scale up. It's not coming from the last 2 years. As you say, it's true that GeneXpert machine to be deployed in 2012, 2015, it was very challenging because we need to set up the lab to look how the lab works, to be sure that we don't have dust and so on. We have air conditioner and everything. Then it was, as I presented in my slide, one of the slides, it was a joint effort from Global Fund, using the NSP, from USAID, from CDC with different, and it's also been integrated with HIV and other diseases. Is to say, to summarize, that the leadership at the Ministry of Health, APHI, work with all partners and donors to be sure that the implementation goes well. The second is on network. Ethiopia is one of the countries who are facing connectivity because they have in the past only one monopole service provider. Then we have this challenge, as I say, previously we have a connectivity tool called EDCTP, and coverage was not 100%. We have also challenged to upload data in some catchment area. What we try to do is to use card, and then when the network is back, they can upload the data in, not in real time, but we can have access to the data later. Now we move to a new platform, new tools, connectivity tools, but at the same time also, Ethiopia has embraced the, what they call the agenda for centralized information system agenda. And Ethiopia has developed an integrated package, which is led by the Ministry of Health, where you have the surveillance system, you have the supply chain, you have TB program, HIV, all program is under the Ministry of Health. Then APHI is representing the lab network, including disease program and surveillance, and they are working with Ministry of Health to be sure that the confidentiality, all the policy according to the country level. And this is a good example for sustainability. Lab is not one pillar, is integrated in a big architecture, information architecture leading by the country and Ministry of Health, but working with other ministries because it's they have a One Health approach where we have Ministry of Agriculture and Environment also there included. The last comment I think was on data security. I think I addressed it. Is led by the Ministry of Health. We have a confidentiality policy which we are using.
Given the timing, we have to move on. There are many questions, and I think all valid. And if you can hold on to those, and I have seen a few smoldering looks on that side, waiting for the questions to come. But I wanted to thank all of the presenters for their time on this session. And please do approach if you have questions. We might have time at the end, hopefully, if there's anything remaining, but we do have to move on with the session. Thank you so much. And I'd like to introduce Dr. Vinze Lucas, who is a scientist at FIND in the TB program. He's based in Cape Town, and he will be chairing the next session. Vinze has been working as the trial manager and lead scientist for the TB CAPT consortium, and has an immunology background, came from Stellenbosch University, and we're super glad to have him on the team and also the community. Thank you, Vinze.
Thank you very much, Adam, and thanks to the speakers in the previous session. I'm very happy to chair this next session titled Expanding the Rapid TB Diagnostic Toolbox, and we will introduce some exciting evidence from the TB CAPT core trial to inform scale-up of decentralized molecular testing to expand access. So to set the stage for this session, Dr. Lucy Mufumi, the Diagnostics Project Officer at the Stop TB Partnership, will talk to diversifying the technology landscape to fill gaps in access and achieve more affordable testing. Over to you, Dr. Mufumi. Thank you very much.
Good morning, everyone, and thank you to the ASLM for this invitation to share some of our experiences from the INTP, and Dr. Alain alluded to it a little bit. And if you've been in the session since the beginning, this is no longer a new slide. We've seen this, but I just putting it there to just say this is really an exciting moment in the TB world. We have all these options that are now available. And not only just the rapid diagnostic tests that are available, but we also have even more guidance that is available. And what I alluded to earlier, just the WHA resolution on diagnostics that is really showing the importance of diagnostics in the entire cascade. And also just to mention that we also have research consortia that are looking really beyond sputum and even trying to bridge that gap from new diagnostics to actually getting them into implementation. So just to talk about TrueNut, which is a sort of new addition to the tool for it does not really get affected by dust, which has been mentioned earlier by a colleague that is an issue with the gene experts. And the instrument itself consists of a true prep, which is where you do the DNA extraction, and then the true lab, where there are three options for the true lab. You either have one pot, or you have two pots where you can put the different chips, or you can have the 4 chips where you can do more tests. You can do 4 tests at a time, and the different cost options are shown from 10,000 to 18,000 for the 4-chip pot. And excitingly, just this year, the price was negotiated by Stop TB USA and Global Fund, and it came down from $9 per test to $7.90. So this is quite exciting. And also, for every 100 MTB tests, remember I said that there are 2, or you first have to detect TB and then reflex for MTB WIF. So for every 100 MTB tests that are purchased, you get 20 MTB WIF tests for free. And there's also the negotiated prices available to both public sector and non-profit buyers. And the warranty is initially for 1 year, and you can optionally extend it for every year. And that initial 1-year warranty includes technical assistance. It also involves a visit. It can be remote. It also involves a visit by the service engineer as necessary, and also the repair and replacement of any parts or swap out of any instrument in country. And the annual extension costs range from $800 for the different options for the True Lab Analyzer. At the same time, the DDF at Stop TB has also, Mobile has agreed on a set of KPIs around service provision that will be monitored every month and reported to countries as well as to the GDF. And this really monitors the system uptime, monitor the responsiveness of Mobile and its service engineers to any requests for repairs. So I'll talk about the Introducing New Tools project, and this was a USAID-funded initiative. And again, just to reiterate that this was really at the time when we wanted to assist countries to reach the UNHLM targets. And I'm showing you the 2018 targets, and that by 2022, the progress was really not great. And just to show you again, as Nazir has already shown us, that we're really falling behind on identifying people with TB and even using the rapid molecular diagnostic tests that are recommended by WHO. So the project was in 9 countries that are part of the USAID priority list, and we gave through 301 TrueNut instruments to the 9 countries, ranging from 20 to 38 instruments in each country, and the installations were between December 2021 and June of 2022. So, as you can see in the pictures, it was really interesting to see how TrueNut was implemented in the different countries. Primarily it was at microscopy centers, but other countries really used them to meet patients where they were. In one country, in Philippines, as you can see on the extreme right, we're really taking the test out to the communities. And this was really exciting that people were receiving care where they needed. And in those countries that put TrueNut at the facility level, they were really looking at the lowest healthcare facility, and that also had a reliable sample transport system. And there were some minor renovations that were needed at some sites, but they were not major. So just to talk about the TrueNut error, invalid, or unsuccessful results rate, as Nazir had mentioned, that one of the benchmarks is to really be monitoring the error rate with these new instruments. And with the so again, as I mentioned, there are 2 steps in the TrueNut testing. So the True Prep and MTB Plus, where you first detect TB, and the MTB WIF stage, you can see that on the main graph here, you can see that there was really a variation across countries, and we're seeing a really the error, invalid, or unsuccessful results were really highest on the MTB WIF step. In some countries, not so much, but in some countries, we were seeing the error, invalid, and unsuccessful rates go up to 30. But you can see throughout the implementation period that those error, invalid, and unsuccessful results then declined. So some of the lessons learned was that really TrueNut testing improved accessibility to rapid molecular testing at the lower health facilities, and up to between 60 to 90% of newly diagnosed people with TB were tested with TrueNut. Of course, we would really want us to get to 100, and we can discuss later in the panel what were some of the issues. And some of the things that really helped with acceptability of TrueNut testing was that early engagement with key stakeholders. And we also created a platform where we would have regular webinars with the implementing countries to share knowledge, and also mission trips that help to understand some of the challenges with implementation. And some of the feedback we were getting from countries was that the mobile local agent, and there was a local agent in each country, were really responsive to their queries and were able to offer remote and on-site support. And the KPIs that have been submitted so far also show the same thing, that they are meeting the targets that we agreed on. And I put this in bold just to highlight some of the issues that came up and have already been alluded in previous discussions. The high staff turnover that necessitated the retraining, and also while TrueNut was useful in community settings and in active case finding, the throughput of that two-port TrueNut instrument that we provided was sometimes not sufficient when you have a lot of samples to test, and some countries were then able to then also use the TB lab or refer some of the samples to an expert testing site so that they meet that same-day diagnosis. Additionally, the batteries also work for up to 8 hours, so at sites that had prolonged power outages, this was a problem. And as I've mentioned, that the TrueLab chips need to be stored at 30 degrees. In some countries where the temperature exceeded 30 degrees, that also became a challenge. So in terms of the next steps are 5 of the 9 countries have already updated their diagnostics algorithms and included TrueNut into the algorithms, and they're going to be scaling up with global fund resources. And with the IDDS project that we're also working on in this, where we're assisting countries with EQA, but as that project funding ends, there's also need for countries to plan for sustainable EQA going forward. Connectivity was also challenging, and Dr. Lane has already alluded to the lab expert that was introduced in Ethiopia, and another country, Kenya, was able to also develop their own system that they were able to connect all the TrueNuts to. There's also validation of stool testing that is ongoing on the TrueNut analyzer, and mobile is also, the TrueNut instruments are also capable of multi-disease testing, and mobile is in the process of applying for pre-qualification. And I'm just going to highlight some of the resources that are available, and you can access this on our website. And I will acknowledge the USAID for funding, and I'll just end with this quote from Dr. Tedros that asked, are we really ready to write the final chapter for TB? Thank you.
Thank you very much for the presentation. We'll allow 1 to 2 questions right now from the floor, and you may please take the mic.
Thank you for the informative presentation. My name is Moko from Lesotho. I have just one question concerning the temperature. I could see that the temperature that the chips and the instrument can operate on is between 30 and 40. For the excessive cold temperatures, how is the instrument affected? As in Lesotho can go as minus degrees Celsius. Thank you.
That is interesting. I'm not sure we have any data on excessive low temperatures. I think their range is probably from 18 to 40 for the operation conditions, but I'm not sure if we have someone from Ohio in the room, but we'll definitely put it down to ask them for Lesotho where the temperatures get below. Did you say minus 12? -5. Okay, we will confirm with the manufacturer. I don't think I have a clear answer for that, but that is interesting. Thank you.
Thank you, Dr. Mfumi, for your presentation. I have two questions. You mentioned that there was a high staff attrition. Would you care to share what type of cadre is being utilized for implementation of this? And the second question is, on the error rates, were they machine associated or they were cadre associated or healthcare worker associated? Thank you.
Thank you for that question. So I'll start with the first one. So mainly it was people were, because most of the sites used previously microscopy centers, so it was really technicians who work at microscopy centers, but we've just been made aware in one of our countries, they actually use almost community healthcare worker level, but that were trained to be able to use the TrueNut instruments. And when we're trying to analyze now to see was there any difference in the rate of error, invalid, or unsuccessful results. And that's a nice segue into your next question. What we did was to combine, when we asked for data, we just asked what were the number of error or invalid or unsuccessful results. So it's not really just the error rate, but it sort of encompasses all. And we were finding, particularly on the MTB RIF, that's where they were getting a lot of invalid or RIF indeterminates. And some countries would have more of MTB RIF invalid results or more of MTB RIF indeterminate. So that might, for the invalid, that could point to maybe some pipetting issues, but for the RIF indeterminate, it could be maybe there was low bacillary load that resulted in a RIF indeterminate, and we're still teasing through the data to really see what were some of the causes. But I think it's encouraging to see that by the end of the project, we were seeing that those rates were going down. But of course, we really want to reach the 5% target. And for this project, GLI and Stop TB had actually put a target of 3%, which was even more ambitious. So we'll keep looking through the data to see what and discuss with the countries as well.
Sorry, I think we have to move to the next presenter just in terms of time. Up next is Dr. Salsa Koza. Dr. Koza is the Director of CISPOC at INS in Mozambique and will share data from the TB CAPT core trial where we assess the effect of decentralized molecular diagnostics for TB using the mobile TrueNut platform and TB assets.
Good morning, everyone. First, I would like to thank ASLM for the opportunity to present results of the core trial on behalf of the TB CAPT consortium. I have no conflict of interest to declare, and this will be the outline of the presentation. Well, first I have to thank Dr. Lucy for simplifying this slide, basically. So the TrueNut is a PCR-based system. As was said before, you have a two-steps to make the diagnosis. It's compatible, portable, and random factor, as said. This was the setup that we used in the study with the two the structure, the analyzer, and also the printer. And the TrueNut was endorsed by WHO in 2020. The core trial was a pragmatic randomized control trial to assess the impact of implementation of the mobile MTB assay on the TrueNut in peripheral health centers. The study was run in Mozambique and in Tanzania in peripheral health centers, and 4 institutions were part of the trial, 2 in Mozambique, INS and CISM, and in Tanzania we had the Fakar Health Institute and NIM. The primary objective was to evaluate the effect of testing TB using TrueNAM platform, combined with the rapid communication of results in primary healthcare centers, and the treatment initiation in microbiology confirmed case within 7 days from enrollment. We had 29 clinics in total, and you can see down here that 14 clinics were in the control arm and 15 clinics in the intervention arm. And maybe just go one step back. And just to clarify, the difference between the control clinics and the intervention clinics was that on the intervention clinics we had the platform deployed, while the control clinics.
I am Dr. Lila from Memory, all the way from there, Tanzania. So I am here to present to you on some analysis we did on costing, because the TB CAPT trial, TB CAPT co-trial that Dr. Sanso has presented had a costing component. And so I'm going to talk on the health system costs of decentralized TB diagnostic testing using bioinstruments versus hub and spoke platform that used the gene experts in Mozambique and Tanzania. So just a bit of a reminder, Dr. Celso has talked about this. In the TB CAPT study, we have the standard arm and the intervention arm. So in the standard arm, like usual, a patient will come to the clinic and suspected or presumed to have TB due to the symptoms in the clinical presentation, and the sample will be collected. This sample will be sent by using different modes of transportation, including motorcycles, to the testing laboratory that would use the gene expert machines, and the results will come back. This is definitely not within a day, sometimes not a week, sometimes 2 weeks. And this result will be made available to the testing of the collecting facility, where the patient collected the samples, and this will take some time to be available. The patient will get the results after they come back to the facility. This was different in the intervention, where the patient was able to collect the sample on the same day, testing performed using the TrueNAM modifier on the same day, and the results will be available on the same day. So what we did in the costing study, we collected data, and we used a modified society perspective to do the estimation of the costs. We had two parts. We had the health system costs, but also the patient costs. And these were the endpoints that we used in costing, estimating the cost. First was the cost per test, but also the cost per TB treatment initiation within the same 7 days of TB testing. In the cost effectiveness part, the endpoint was incremental costs per additional patient linked to TB treatment within 7 days. So this is still an ongoing analysis that is being undertaken by the team. For today, what I will be presenting to you is the health system costs, which will tell us the cost per test. Later on, after the patient costs have been put into the model, costing models, and looking at the implementing cost, we'll be able to present the cost effectiveness part of the study, given that the main results of the study, the main outcome is now out. So we did a combination of micro and macro costing. And at 3 levels. At the facility level, we were able to interview costing coordinators from the 4 sites who were managing the 29 clinics across the 2 countries. And also we used some implementation cost tools, which I'll show you in a bit. And also we used the trial expense report, which gave us the costs for what we were able to intervention and what we were able to install in the facilities. And also we used some product catalogs to triangulate price testing, especially for the platform gene expert and the TrueNAM program. So these were the implementation costing tools that we used. On the right side, we have site costs, and these were the costs that the sites incurred in introducing the implementation. So we looked at whatever the costs incurred in staffing, the training of the staff, installation of equipment, as well as monitoring and some of the administration costs. But also we had external laboratory. These are where the samples have been taken, are being referred to. So we went and assessed what are the costs that this health system is incurring in running the samples from the time they the samples at the facility, at the testing facility, to the time the samples are now being released to the clinics. And then in the clinics itself, we looked at both the intervention and the control clinics and saw what are the costs that the health system incurs in making sure that in all the process of making sure that the sample is collected, who is responsible, what are the consumables that are used, what are the diagnostic sample referral system used, whatever costs that are incurred in all of this were collected. So later, after we have collected this, we categorize the costs into 8 categories, which are cartridge, other consumables, which include things like gloves, reagents, as well as transportation costs. Later on, we were going to see how this was it came out a bit different in the countries. And then equipment, warranty, maintenance, training costs, communication, including internet, including airtime, as well as staffing miscellaneous costs, such as the bills that are incurred at the facilities. From there, we got the estimated ranges of the cost and put them in the Monte Carlo simulation model to get the estimates. And these were our results. So the estimated cost per participant tested using the TrueNet mobile was $53 in Mozambique and $42 in Tanzania. While in the standard of care, that is the hub and spoke model, using the GeneXpert machines later testing labs, the cost per participant tested was $40 in Mozambique, while it was $21 in Tanzania. So just a bit into the categories of the costs. As you can see, it is progressively that in the intervention, which is using the TrueNet mobile, we had higher costs per test compared to the standard of care. And this was different with the cartridges because the cost of the cartridges for TrueNet mobile and that of GeneXpert, the GeneXpert one is a bit expensive compared to the TrueNet mobile. So this was consistently the same, but you can see that major differences are in equipment, in warranty maintenance, as well as staffing. These were not pronounced, differences were not pronounced between the two arms. And remember, this is just the health system costs. And that was for Tanzania, and for Mozambique, it was not different. It was the same except for the other consumables, which may. So in Mozambique, we have the other consumables being more expensive in standard of care. Remember, with other consumables, I mentioned that transportation is one of the costs that, and it really depends on the network, the sample referral system between the two countries, how long it takes for one sample to be referred from the collecting clinic to the testing clinic. This would explain the differences in Mozambique compared to Tanzania. In Tanzania, we have a lot of GeneXpert machines placed in different levels of the healthcare system, even in the health centers, which is the second level. And this would explain the smaller differences in transportation of referring the samples for testing. But otherwise, it is just as in Tanzania, it is consistently that intervention and higher cost. And so the takeaways are that using the decentralized molecular testing, we saw that this was more expensive in the hub and spoke approach. But let us not forget the main important thing here is that using the hub and spoke model, you will be able to test a lot of samples compared to when you're using the decentralized testing. So what we are looking at here is the cost by the number of tests that are taking place at the facilities, not just that this is more expensive compared to the other. So it gives us thought into how well can we place the TrueNet mobile testing platforms so that we can use them optimally, we can maximize the use. And this is not only in TB, but then how can we use the TrueNet mobile in other tests so that this cost can be shared across the programs, but also the tests can be shared across the number of tests. So that is just something that we should look at. And also let us not forget that this is just the healthcare system perspective of costs. We still have the issue of the patient has to come back again for for the results. They have to come to use transport to come back and collect them. But also you're likely to miss a person if they're coming from a long way and you're not giving them the results on the same day. You're likely to miss them, to start treatment on the right time. And how much is this going to cost the system if they go out there, public health wise, transmission and everything? You're more likely to have a lot of costs in the long run. So once we have added and included all of this into the costing analysis, I'm sure the next day we'll have everything at hand to come and present to you. So I would like to thank the great work that is done by the consortium members to collect all of this information and the team that is still doing the analysis as we speak. Thank you very much for listening.
Thank you very much, Dr. Miller. Do you have any questions from the floor? Yes, class.
Thank you very much. This was a really interesting presentation to listen to. And I really appreciate the end note that you gave, the caution regarding, the things to consider, to think about, apart from just the differences in the cost. I just wanted to understand the cost implications, or the cost difference that was seen in I think Tanzania, when you showed in the staffing for the intervention costed a lot more. Is this because this was just, the initial training costs and stuff while the other platform was already established? Or was there any other cost driver for this intervention arm? Thank you.
So I think the major differences between the two countries was with the other consumables, where in Tanzania we had lower in the standard, while in Mozambique we had higher. So with the staffing, yes. So with staffing we had, yes, when you compare between the two countries, you can say we have a bit lower in Tanzania generally, but still the trend is the same. That is, intervention on it is high compared to, and it is understood that in intervention, because we have a lot of platforms, you need to train more staff in all the levels, while in the intervention arm it's because it's only central, and in the central level you just have to train very few staff compared to. But the other thing is, when comparing the two countries, what I could say with the intervention versus intervention in Mozambique compared to, the difference is slight, about $3, yes. Maybe because in Tanzania we have the staff that are being trained, they are in a position in the health center facilities, compared to in Mozambique, they're in a higher level, and the control room in the higher level compared to in Tanzania, where they're more in the health centers, which is the second level of healthcare delivery in the country. So I think that may explain the difference. I don't know. It's just thinking that could be the reason.
Thanks a lot. Very interesting presentation, and give the idea of looking at patient-centered cost as well in the bigger picture. So I think that's fantastic. And a few words to the first is around the time horizon for the analysis. It's like a 3-year, 5-year, 20-year, and time horizon we're looking at. So costing the equipment and depreciation over time. That's the first question. And the second is how sensitive was this model to volumes of testing? How sensitive is a model to, say, a volume of testing? Obviously, inside maybe a primary healthcare clinic, there is a lot of high volumes of patients being tested versus a clinic that might not have that many. How would that impact on you?
So with regard to the time, we collected all this information from the facilities within the past 1 year. How many patients, how many samples have been done in the past 1 year? How much have you been using in the past 1 year? But
yes, it is more about the time horizon where you're looking at the cost. Like obviously, you buy a piece of equipment. They're expecting that a piece of equipment will last for 5 years,
yes.
or how do you depreciate that value of the investment?
Yeah, and for the gene expert machine, the depreciation was considered over a 10-year time frame. Yes, so how long do you expect the machine will be used and how much would it yield and when will it not be useful anymore? The second question was about the volume of the clinic levels and the tools.
First was related to like the volume, so how sensitive is your model in terms of, obviously, primary uptake clinic that sees, 20 cases a day versus another clinic that sees 2 cases a day, how would that impact on your cost of testing?
Yeah, so we did have, that's very, very true, we did observe some facilities that had more patients compared to other facilities. And that would mean that in the facilities that had more patients, we were more likely to see that it is more cost. It is better cost-wise because of the distribution of the cost among the tests. But in those facilities that have very few tests that are being done, then we run the risk of overestimating.
So I do see that there are more questions, and thank you for your interest, but we have to move to the last presentation in this session. So to conclude, we have Dr. Grace Mhalo, who is a senior research scientist at the Ifakara Health Institute in Tanzania. And Dr. Mhalo will share data from the qualitative user perspective component of the contract. Over to you. Thank you very much.
Thank you very much, Lucas, and good morning, everyone. Excuse me for my voice because I think it's windy in South Africa and I catch it. Sorry. So I'll be taking you to a juicy part, the simple science. We're moving from the hardcore science now to the simple thing. And I'll be presenting on behalf of the team in Mozambique and Tanzania on user preference. And this was a qualitative assessment of usability, feasibility, and acceptability of the asset. And I'll be as quick as possible because social scientists speak a lot. I'll take the time. So our primary objective for this study was to investigate user perspective of the TrueNAT, including perspective of the end users, patients, lab technicians, clinicians, as well as decision makers. But we also wanted to compare and investigate experiences and challenges with the diagnostic testing that I made TrueNAT as compared to other different approaches, example, culture, microscope, and gene expert. We also wanted to assess the feasibility and preference with regards to TrueNAT among the end users and how these factors might change. And also, lastly, to assess usability and acceptability of the TrueNAT platform. So how did we collect the data? So we did semi-structured interviews, but also we did direct observations and surveys. These surveys were divided in two. We did ease of use surveys, but also what we call system usability surveys or system usability score, where we used a Likert scale questionnaire of 5 points and assessed the healthcare providers, the lab technicians, to say those who were using the platform on how is or not is, or how confident are they to use the test. We did this with patients, healthcare providers, those who were using TrueNAT platform especially, decision makers, as well as users of the TrueNAT in the intervention facilities. And this table shows the characteristics of our participants, as you can see, for the system user acceptability as well as the direct observation. And as usual, we interviewed a lot of lab technicians because these were the users of the asset. And the years of experience, many of them had 10 years of experience working in labs or in these health facilities. And the time used for the devices, many of them used the devices more than 10 times. And this was very important so that we can have a diversity for those who used less and those who used more. So we had a diverse group on that. So for the usability and ease of use assessment, as I said earlier, our mean score was 90 and it ranged from 65 85 to 92. This was for the system user survey or system user acceptability, but also for the observation. For the direct observation that we did, and I will point out that the direct observations, we not employed some of the lab technicians of the research staff that were trained on how to use the assay, went to these facilities while the tests were conducted and observed the lab technicians / the nurses when they were using the devices and documented. And this was done for almost like 4 or 5 patients. For the observation, most frequently error that was recorded by these research staff was forgetting to check the internal control of the line cartridge, and this was 6 out of 12. But also all participants mentioned feeling confident in using the assay, and also most of them they said that the components of the TrueNAT were very easy to use, 6 out of 12 as well. We did some interviews, and for us, we usually present the common themes and what happened. And as you can see from the table, we had interviews in Tanzania and Mozambique, and that was the total interviews we did. For us, qualitative researchers, this is a lot and a very good data, 58. I know for you guys it will be a bit, the sample size is small, but I assure you that we reached a point of saturation with this and be confident that these results are very, very fine. So for the common themes that we observed, you can see the workflow at the facility, this one here with the red. This was something that was coming out most of the time, that the providers say the workflow has changed a bit because of the use of the assay, and now they can be able to do the procedures, the diagnostic test in a very short time, so the patients were not staying in the facility for a long time. But the time to result also was very common observed. They say that now with the TrueNAT, you get the results at the same time, at the same day, as compared to other assays, example, GeneXpert and microscope. So for the time to results, we interviewed depending on which diagnostic approach was used, whether microscope, GeneXpert, or the sample was taken to another facility, and if the patients were required to come again. And this time to result ranged from same day, and this was for TrueNAT, to 2 weeks. And 2 weeks for those facilities that we are sending the samples to other facilities because of diagnostic capacity, if they did not have enough diagnostic capacity. And one of the providers say, with TB result, for example, if the sample has been brought in today, the patient needs to come back tomorrow or the following day for the results. But this has changed with the TrueNAT. Now patients can be able to have their access to their results on the same day. We also interviewed on what are the challenges, and supply of reagents and cartridge was common also, not only for TrueNAT, but also for GeneXpert, and this actually is known before even we got TrueNAT assay. And they said availability of cartridge and reagents was an issue and potential cause of delays. And this is something that we should look at when we are trying to roll out the use of not only TrueNAT and GeneXpert in all this, but even every other assay. For example, for TrueNAT, one of the providers said the reagent should be made available all the time, and all the pieces of equipment should be enough so the patients don't return, meaning the patient gets the results and goes back home on the same day. We asked on the relative advantage of TrueNAT in terms of other available diagnostic tests, and it was more prominent in facilities with limited testing capacity, as all other presenters have said. But the time to result also was reduced, and this was a very common theme among those who we interviewed. For example, he said, I think it's more to decrease the patient cost, which is good, because currently the patient comes and makes many visits. We run the risk of losing this patient, and this can happen with the machine, like TrueNAT. So when the patient are getting the results on the same day, it is very helpful for them, and this has been a very common theme. On adaptability and acceptability, as I said earlier on our observation and system score result that I showed, it was perceived as acceptable and fit to the context, and also again faster time to result and increased testing capacity, which was also considered beneficial, as you can see alluded by some of the quotes that we've mentioned. So, for example, it says, so I have generally developed the morale, or as even when we use the say to our HIV patients, can be tested and start the treatments on the same day. So it's all about starting the treatment on the same day and also time to result. So we also, on the same issue of adaptability and acceptability, they also mentioned the need for adequate infrastructure for sample processing by some providers, as I already mentioned before, that this was recurring throughout. So for this assay to be able to work correctly, we need everything to be in place so that the assay can function in our health systems. We also interviewed the patients, and we're still doing the analysis, and these are the patient findings, and they said the patient preferred the same day diagnosis. But interestingly, some of the patients say it is okay if I come back tomorrow, but I have an accurate result. So I don't mind at all. Of course, without considering other costs, like other factors like cost, transportation cost, and time, and all this. But they also supported the diagnostic process, and they say patients, the healthcare providers were very supportive when counseling, supportive when they received counseling from the providers. They only know that in order for you to have a TB diagnosis, you need a sputum sample. They don't know any other way. So it is for us scientists now to start introducing these ways actually as a blend today of urine, which is very good for us scientists. It's something new. But as we all know, fears of stigma is still there, and this is something that has been common throughout. And this also came out that after diagnosis, many of them are very fearful that they'll be stigmatized, not only in Tanzania, but this is something within our health system and in our community. And with this, I would like to acknowledge the team, Maria, who has really helped preparing the slides and all this, and together with those in Mozambique and Tanzania. And I hope I kept the time, and thank you very much.
Thank you very much, Dr. Mali. We have time for just one question from the audience. Yes, you may proceed. The microphone.
Thanks for the presentation. Listening to the different speakers, I'm just thinking, the time when different platforms have been introduced, we'll probably have the same kind of results, because we're probably putting everything in place for this to happen. We need the numbers, we want to do the analysis. I just wonder if you were able to throw this out there in the nature and see how it survive. Because probably other platforms have the same results like you presented now, but by the time you got into the nature, it changed. So I think it would have been good to see how it would behave in its natural environment without making sure everything was working within the framework of a project. Now, my question would be, did you evaluate the TAT, the turnaround time for linkage to care? So we've seen turnaround time to results. Were you able to go down the cascade to see turnaround time to initiating treatment? And as opposed to same day and coming probably the next day, the next 2 days, the next 3 days, what difference would that make in the care treatment, the quality of care treatment? I think that would also add value. And thinking about introducing and scaling up this technology, we don't want to end at the level where patients are getting results. We want to also think about how they initiate quality care for their care treatment. Thank you.
Thank you very much. Although this was not part of the objectives of what we were looking at, but within our qualitative data, we have a few suggests that some of the patients that came for care, they were treated on the same day, and treatment initiation started the same day. And this was very true for Tanzania. I cannot speak that much for Mozambique. Yes, he's saying yes for Mozambique as well. So it's not only for the diagnosis, but many also for treatment. I might not say only for the single day, but then, you know, turnaround time for treatment can take even a week in some of our facilities. So for these, some of the codes suggest,
and I'm just going to highlight this again, sometimes there's a little bit of a confusion around perhaps this is only advanced HIV disease patients, or only those with a CD4 test count of a certain level. But this is really a more comprehensive recommendation. And this is based on several considerations around LFLM testing and a body of evidence supporting this. So not only does LFLM testing facilitate testing of PLHIV for TB that are unable to produce sputum, and not only is it a simple test that has minimal infrastructure needs and does not have equipment that's required for supporting it, but it also can be conducted by lab and non-lab testers at true point of care. This could be at bedside, this means community settings, without any need for recharging or any kind of battery that comes with some of the other molecular equipment we've heard of. While the sensitivity, which is often discussed for the current LFLM test, is relatively lower than the molecular assays that we have available in the market, as shown in the comparative table here, the specificity is similar between these. And so this gets to Puneet's point from earlier today about the yield of these assays. It means that when LFLM is implemented among this population, you end up with a higher overall diagnostic yield, because you can detect and rule in more patients than molecular tests can detect alone in a single day with the most rapid test result that we have. Where this study, as backed up by other studies since, showed that the day one diagnostic yield in HIV positive inpatients was doubled over expert and TB RIF tested individuals alone. Lastly, this is the only TB diagnostic assay with a clinical trial-based mortality benefit in this population that experiences increased rates of mortality. Despite all of these potential advantages, those that are familiar with the field of TB and have heard of LFLM will know that there has been a really slow uptake over time. And access to LFLM testing still has not achieved the reach that we would like across all of the patients that are now eligible according to WHO recommendations. And this is really due to a whole suite of barriers associated with LFLM implementation, some of which are just cross-cutting with point-of-care decentralized tests, irrespective of the test type, and some of which may be specific to LFLM. So for example, lack of coordination between TB and HIV programs at a national level, concerns over lack of algorithm adherence, unclear patient eligibility. Is it those advanced HIV disease patients only? Can we taste HIV negative individuals if we really are concerned about them? Low confidence in the test performance, and for example, lack of urine management strategies at sites that have not traditionally utilized that sample type. So why are we talking about quality assurance? I think usually when we say a quality assurance package, people think about proficiency testing and some of these other elements. But we have learned from other diseases, HIV, malaria, that quality assurance components and systems can help to address many of these barriers. We've also learned this in TB with molecular testing, with near point of care testing. So things like establishment of test-driven and characteristic-specific governance structures, new method validations, network assessment, having standardized procedures available, training and competency assessment materials, quality control documentation, a place to capture your test result in aggregate and then review those data and understand performance, and standardized site readiness assessments and quality assessments can all help to address these specific barriers that doesn't need always to be an incredibly complex solution. Sometimes you just need the tools and resources customized to where you are in order to be able to address them. So to address this, I'm very excited to be the one up here announcing that the Global Laboratory Initiative launched today, just about an hour ago, this LFLM Quality Assurance Package. So please feel free to use the QR code. It will take you to the website where this has now been packaged. The tools are available. I will show this again at the end of the presentation, so no need to rush. And I am going to speak through the components of this package. So The quality assurance package that has been launched provides a set of customizable documents to implement a robust quality assurance system specific to lateral flow LAM testing, although doesn't need to necessarily be specific to this exact available test. There's opportunities to customize it as new lateral flow LAM assays become available. It covers the planning phase for implementation, the implementation phase of use, which many countries are in now, scale up, monitoring, evaluation, and continuous quality improvement, and provides a user guide shown here that describes QA system components, including establishment of that governance structure that includes and considers key stakeholders from the different disease programs to be included based on country best practices that we've captured through informal questionnaires. The lateral flow LAM QA package, in addition to that user guide, includes several procedures associated with method validation. This is probably the one we get the most requests for, honestly, is new method validation to establish local evidence for performance of the test, Mentor for TB LFLAM testing procedure, and a urine collection and storage procedure for LFLAM quality control. The next most common request that we get is how countries can use or have access to locally developed quality control materials not currently available with the test. And so that will be in the next version of this procedure. In addition, it includes customizable forms for site and above site use, training and competency assessment of testers, of healthcare workers, of training of trainers that could be located at that site, 2 different Excel-based tools, and training materials. For the training materials, they provide a series of modules, and they are intentionally designed to be able to train both healthcare workers, stakeholders, as well as testers, so that you cover all of the cadres of staff. They provide an overview of the information here, but I'm just highlighting on the bottom of the slide that they also include stepwise review of case studies and algorithm practice steps, so that particularly healthcare workers have a sense of being able to interpret that result against molecular tests and against availability of other test types that may come back. In addition, there are 2 of those Excel-based tools that I mentioned. They both include automated analyses. What's shown here is a snippet of a site-based quality and performance indicator tool where sites can put in the number of their tests, what the result was, and whether or not those were reported on the same day in order to track their positivity rates, error rates, and success rates, and turnaround time all in one collected view. There's an above-site version of that as well in the tool. And there is also a diagnostic cascade analysis. This can be tracked at the site or again above site level that looks at the number of patients that are eligible for testing, tested positive, all the way through treatment initiation. Lastly, there is an automated tool modified from HIV rapid testing that can be used for site assessment and quality. So with that, this is the QR code one more time. For those that are interested in reviewing the package materials, we would love to receive feedback on these as countries begin to use them and implement them. And I would like to acknowledge the organizations here, but particularly those with the stars near their name, the late Sibo Simudo and Rogers Kasame, who were really the contractors to drive the development of this package and the early material.
Thanks, Patricia, and I'm sorry, but we're not going to be able to take any questions. We are quite pushed for time. So I'm going to call up Adam, who really doesn't need any introduction, but we've spoken about urine. We're now going to look at a different specimen type, and there's a lot of interest around this, and you get to be the first person at the conference today to mention the word oral transport. I hope. As an additional right. Adam, over to you. And I'm sorry I'm going to be pushed for time.
Thank you. Hello everybody, I'm Adam Nicholson, the Deputy Director of the TB program for FIND. I'm based in Geneva, South Africa. I'm happy to be here. To skip through, TB is a problem with lots of cases. We get it. affordable, such as digital chest X-ray paired with computer-assisted detection or CAD using AI solutions. And there is a large pipeline of tools that are currently being evaluated that can be used for sputum smear replacement, using sputum or other samples, as well as expanded drug resistance detection, which is extremely important to protect the drugs that we can use. And so our mission is to ensure equitable access to reliable diagnostics around the world. We do not manufacture any diagnostics, we don't sell anything. We're a non-profit organization working with WHO to ensure, and we're headquartered in Geneva with offices in India, Kenya, South Africa, and Vietnam. And our objective here is to connect countries and communities, funders, decision makers, healthcare providers, and developers to really spur diagnostic innovation and bring testing to the patients in need. Right? Currently, complex testing systems that can identify multiple diseases rely on specialists and well-resourced laboratories. But the pipeline of multi-pathogen molecular tests are simple enough to be used in primary healthcare clinics. It's been kick-started by the COVID pandemic. And so how will we get these tests to the patients? Well, the technology landscape has advanced greatly over the last years. There's still a trade-off between performance and multiplexing capacity and operational characteristics such as suitability to level 1 settings and cost. So it's not really that there's a one-size-fits-all solution for diagnostic testing. We're aware of that. And we believe that if we can increase access to diagnostic tests from about 25% of the population to more like 75%, even if we have a decrease in performance and accuracy of those tests by around 20%, we could still more than double the proportion of people who receive a test and receive an accurate result of the diagnosis. So this is that diagnostic. And we've modeled this, and I think as you look at the back there, we did this work. We modeled it both in Kenya and India, and here, well, a bit complicated if you look at the India graph. The same number of individuals could be diagnosed and start TB treatment using a non-sputum-based test like a tongue swab, shown by the green line, right? With a hypothetical 15% reduced sensitivity. If this test was placed near point of care compared to our current standard of care, which is offsite expert testing, which is the green line. So I mean, even a reduced performance test can still diagnose as many people who put in a high risk. And Dr. Celso so eloquently showed this in the test in the TB CAPT core study that in Tanzania and Mozambique we can do same-day test and treat strategy. And I think you can imagine how this would expand if we could also do those tests for people who are more sputum non-productive in other hospitals. And in fact, this is exactly what we've done with Andrew Medina from the Deaf Community to Health Foundation, for the University of Victoria, in the Buffalo City Metropolitan District of the Eastern Cape, where a portable expert edge instrument was taken into the households of contacts of confirmed TB cases. And out of 630 contacts, only 37% of them were able to provide a sputum sample, whereas 98% of those participants were willing and able to provide a tongue swab sample. And the positivity of rates of sputum was 11%, and while it was lower for tongue swabs at 6%, we actually did land up finding 12 more cases who were identified as TB cases through the tongue swab alone. And so I think this really does indicate the placement of the instrument, and there was also incredible, I think it was 100% linkage to care when we brought the test into the household. So we would be very optimistic that 2023 was going to be the year of the swab. You may have seen this. We're still in 2023, and we do have some exciting data. And there has been a lot of evidence generated, and this systematic review is actually going live today by China Church on the Lancet Global Health, so do look out for it. And we see sensitivity of tongue swabs ranging from 36 to 91%, and specificity from 66 to 100%. There's been a lot of variability in the steps of collection, populations, and different reference standards. And what we try to do in 3 large consortia of RTPs and defendants, smart for TB, is trying to generate evidence using a consensus protocol for tongue swab collection on expert ultra. And I'm not going to have enough time to go over the data, but I think where we can see is, if you look at the sensitivity column, these different groups and different populations and different geographies are all settling around the sensitivity of tongue swab of between 75 and 80% relative to reference standard sputum ultra positivity. And MoreBio also has been tested, and this is showing incredible promise as well, although it's still quite early in the data generation. And specificity of the effect. I'm going to skip this, but MoreBio is working on a new instrument to help go from a direct, bypass the true prep DNA extraction and direct to true MAT. And we'll see more of this in a minute. And the pipeline is flush with new tools as well that are moving through the process. Data still needs to be generated on these, and we're hopeful and excited for what 2024 will hold for these four. There are other non-sputum-based tests like CRISPR and based assays and cell-free DNA that need a lot more work and evidence, but studies around awareness. We've talked quite extensively about LAM and urine-based assays, and I think just to mention here, we know some of the problems with Fujifilm's Silvamp assay has had a lot of variability, and this is being addressed and still under evaluation. But SD Biosense and Logitech have tools that use a reader that increases signal and simplifies readouts. And Abbott and Salus are using concentration devices and new reagents that really increase the sensitivity. So hopefully we can apply these NAM assays to people beyond just people with HIV or CD4. The expert says a blood-based host response cartridge that is showing some excellent performance, and similarly there are proteomic markers that are being evaluated, and those data have now been unblinded. So it works surprisingly well, and I'm looking forward, and hopefully in Q1 2024 we'll be able to share that data next time. And I think just to finish up on chest X-ray and CAD, there's a huge excitement about this because these X-rays can be taken into the field just about anywhere on a backpack and a van. We're also looking at point-of-care ultrasound, digital stethoscopes, and cough apps. And there's a lot of promising work around this. I think we talked a little bit about running stool on ultra cartridges and finding involved in developing a video with KNCB on training this, and I encourage you to take a look at this. I see work is being done on bio as well. And our last slide, I think we're really ultimately hoping to see an investment in end-to-end solutions for TB diagnostics, treatments and vaccination all in one, within maybe a mobile clinic, paired with a digital chest X-ray and CAD, new sputum and non-sputum-based tools, and integrated patient care, DNO as well, and we're expanding some of this testing to drug-resistant TB testing. So I think this is possible. It's within our dream. We just have to put our effort and our money towards it. And I think we're really out of the stage where there's a one-size-fits-all solution. We know that we can have tests with maybe lower accuracy, but it will lead to higher diagnostic yield, and the impact of that is still to be explored, but it's exciting. There are new drug-resistant TB tests that are in the pipeline to detect those precious drugs that we still have and it's an exciting time for diagnostics and digital solutions. Thanks for this, and I'll be outside.
Thanks, Adam. Wow. Well, before COVID, we were scratching our head as to what new TB diagnostics are there. Now we say, gee, how are we going to manage all of this? So it's really an exciting time, and I'm sorry we couldn't get to ask more questions because this is a power pack of new toolkits. So unfortunately, Dr. Zine Glover couldn't join us. His flight was detained, but he has forwarded a presentation to us. He's an epidemiologist and laboratory advisor for MSF in Sub-Saharan Africa, Asia, and the Middle East. And he'll be talking to us today about operationalizing targeted NGS for drug-resistant TB. And again, this is such a huge topic, and we really need a full session on this. Where does this fit in the pathology value chain? How are we going to integrate this at a program level? So again, you have to keep your questions and contact the speakers later.
Greetings, everyone. My sincere apologies I could not be in Cape Town to present this in person. Nonetheless, I'm going to quickly, because of time, present the experiences from Doctors Without Borders in piloting implementing a technology called targeted next generation sequencing for the diagnosis of drug-resistant TB. So Mumbai city is found in a state in India called Maharashtra, and Mumbai city essentially is known as the epicenter of drug-resistant TB. And one of the wards in Mumbai city is called East Ward, and a majority, well, a significant number of people live in slums within this ward. And MSF supports the national program in the implementation of the drug-resistant TB. So one of the clinics that is supported by MSF is called East Ward. MSF runs this clinic, and this clinic has got a unique cohort of patients with extreme forms of drug-resistant TB. Cohort size is over 1,000. As you see from the left, the profiles of the patients are quite extreme, with very high MDR and pre-XDR cases. Phenotypic DST is, of course, the gold standard for the diagnosis of drug-resistant TB, but we know it takes long to get results. It's unreliable for most practice. So these complex drug-resistant profiles, we sought to explore and implement a rapid technology that can give us a comprehensive resistance profile. And we implemented targeted next generation sequencing, which was called TNGS. And why we chose to pilot implement TNGS is because the equipment for TNGS was already available in the public laboratory called JJ and then we just procured reagents to implement TNGS for the diagnosis of drug-resistant TB. So the objectives of the study essentially were to explore the implementability of TNGS within a public health laboratory, but also to assess the clinical utility of TNGS for rapid clinical discovery. So we essentially enrolled patients who were consenting patients who were testing positive with GeneXpect, and the patients' majority came from the East Ward clinic, and some came from private referrals. And the samples underwent testing through the conventional systems, which is your MGT line probe assay, and on parallel to this, they were also tested in this new technology called TNGS at a public laboratory called JJ Lab. And the study was done from October 2019 to 2020. Essentially, this is the work stream of activities in doing sequencing. So we used the primary sample, the sputum, and the equipment that we use is the Illumina, and the reagents mostly were from GenoScreen. Unfortunately, during the time of the study, bedaquiline phenotypic DST was not yet implemented routinely, and similarly, the technology by that time was not yet capable of sequencing for bedaquiline. But the rest on the left-hand side, you can see all the drugs that were of interest that this technology is capable of identifying the mutations. So as you can see, the mutations are also listed there. Those are the hotspot mutations that this technology aims to detect. And this essentially is just the workflow and the result layout, a color-coded result layout that makes it quite easy to interpret the result. As mentioned, the participants came from public and private sector, and then the resistance is slightly higher there. As you can see the profile of the patients, partly because we deliberately sought to enroll mostly those with rifampicin resistance also, so as to try and determine the characteristics of the resistance profiles within this patient. And in terms of the results, the targeted next generation sequencing predicted more resistance compared to phenotypic DST for most of the drugs, as you can see here. Unfortunately, we didn't have any data on the impact of TNGS on patient outcomes because at that point in time, the results were not yet allowed to be used for patient management. But in terms of our turnaround time for the results for TNGS, we had a slightly quite long turnaround time, mostly because of batching of samples. We had to batch samples, and also there was COVID pandemic that took place. The equipment for startup, we estimated that it cost us nearly, not us, apologies, but the equipment was already available, but we estimated that it would have cost 160,000, but we managed to do a costing for the reagents, consumables for DNA extraction, for amplification, quality checks, and laboratory preparation, which came to plus or minus $230 per sample. Of course, the overall cost we are envisioning that they could become even lesser if patients are treated with regimens. And similarly, we found that the placement of TNGS equipment is advisable at reference laboratories for optimal utilizations, especially labs that are already conducting molecular testing. In this pilot implementation, we did experience various challenges. I think most of this will be highlighted in the manuscript. I'll show the manuscript at the end, but because of time, I'll just list two, which include inefficiencies because we used manual extraction of DNA, and of course, by that time, there was a little understanding of some of the mutations, whether they would be phenotypically significant. And the key conclusions from this study essentially was that TNGS is implementable for comprehensive DST in a high drug-resistant TB burden setting. And also, of course, it's quicker, it gives results faster. Although in our study, our turnaround time was plus or minus 24 days. Recent studies have shown that turnaround time can be as short as 48 hours. And you can find more details about this study within the attached public. So essentially the question now, and why I was asked to present was why should low and middle income countries consider TNGS for the diagnosis of drug-resistant TB? And in this recent publication from Mozambique, this paper showed quite alarmingly high levels of pre-XDR TB. Similarly, for beta-alanine resistance was found to be very high, and actually beta-alanine resistance quadrupled within a very short time. And we also saw the recent paper from South Africa. Actually, the study was done in Cape Town, and the study is demonstrating that 8% of the patients in the study population had primary beta-alanine resistance, and nearly half of the patients managed to acquire or they were reinfected, but they managed to have resistance. So, and in addition, of course, the study in Cape Town also revealed some undocumented variants in resistance. So the implications of these studies, of course, this gives a concern because beta-alanine and linezolid are essentially the backbone of the new DRTB regimen, and it is anticipated essentially that these are our future drugs. So this essentially threatens the national rollout of this new WHO-approved regimen. And of course, given that this is in Southern Africa, there is possibly ongoing cross-border spreading of the resistant strains. So TNGS essentially is the only available rapid technology that can promptly support the implementation of the new drug regimen for drug-resistant TB, especially as we see from the experiences of MSF and others that there is no need for primary culture, as you can use the primary sample, and it can result in reduced turnaround time. And also of late, these technologies are becoming smaller and more streamlined to be benchtop. And unfortunately, prices are still a prohibitory issue, and of course, there's still a lot of monopoly within the diagnostic space, meaning that there's need for more within here. So the other resources that are available, essentially, in 2023, WHO issued a rapid communication that showed a lot of evidence that supported the use of TNGS.